Imagine this. If the third-party payers, if CMS, if the government paid me as a doctor not to record, how many organs did I examine, because that's the way they pay me right now, right? If you come to me with a left toe pain, they ask me how many systems and they count how many systems did I listen to your heart. You get a little bit more if you listen to the heart. You get a little more if you listen to the lungs. Well, why do I need to listen to the heart? You're talking to me. Your heart must be beating. Your problem is in your toe, right? But what if they paid me to spend time designing systems that work better for patients? What if they paid patients to help me design systems that work better for them? And this is a crazy idea. What if we paid patients of a lot of different, backgrounds, diverse, maybe genders, sexuality, racial ethnicities, socioeconomic backgrounds, to help us design better access for them?
Welcome to the Future of Healthcare. I'm Frederick Kaufman, professor of journalism at the City University of New York and a contributing editor at Harper's Magazine. We're here to discuss becoming your own health advocate and coach, living a longer, more vital life through sound decisions and practices. And we have an extraordinary panel with us today. We have Phyllis Greenberg, who is a senior vice president of science and health policy for Healthy Women, an American nonprofit organization which seeks to provide women with in-depth information on a wide range of issues important to women's health, and to increase awareness of those issues via education and advocacy. She's a former president and CEO of the Society for Women's Health Research, winner of the Trailblazer Award by the United States Department of Health and Human Services Office of Women's Health. Women's Day magazine awarded her the 2006 Red Dress Award in recognition of her work in leading the way in the fight against heart disease in women. She has so many awards. She has been named one of the 50 women who are changing the world. And my favorite, the Washington Woman of Genius by Trinity College in Washington, D.C. So welcome, Phyllis.
Thank you very much.
We also have Dr. Jose Azar. He is an executive vice president, chief quality officer for Hackensack Meridian Health. It's a $6.8 billion leading not-for-profit healthcare organization that is the most comprehensive and integrated healthcare network in New Jersey. Hackensack Meridian encompasses 18 hospitals, including 3 academic medical centers, 1 university teaching hospital, 2 children's hospitals, 8 community hospitals, 1 behavioral health hospital, 2 rehabilitation hospitals, 1 long-term acute care hospital, and more than 500 patient care sites and physician offices. It's pretty amazing. So welcome, Dr. Azar.
Thank you.
Of course. This program is the brainchild of Ben Lytle, a healthcare and business leader. He's a visionary, an entrepreneur, an author, and a speaker whose successes include serving on presidential and state healthcare commissions, leading health plan giant Anthem, the national expansion of the revolutionary Silver Sneakers Seniors Exercise Program, and most recently, launching an innovative artificial intelligence company to increase the productivity of healthcare and other professional endeavors. He is the author of The Potentialist, and I can tell you it's a great read, an amazing book about the future and what we can do to prepare ourselves to thrive. So, what do we need to know about becoming our own healthcare advocate and coach? How can we advocate for our health like a professional? Ben, what would be a good place to begin this conversation?
Well, I think I'll just quickly maybe recap for the audience. Although you may have, you probably will have watched the rest of the video, but in case you just joined, really this is that you heard that there are many wonderful, actually mind-blowing things coming down the pike for us as patients out of health and healthcare research, but also that there are real challenges coming that we're facing. Some of them already here, where we've got severe clinician shortages, and that's going to affect access to care. And we've got some clinical risks as well, new kinds of challenges we're all facing now that COVID is still around, and that, of course, complicates the regular flu season. And now we've got RSV on top of that. So it's like a lot of vaccines and a lot of things to be prepared for. So I think where I'd like to start is maybe start with Jose and have him opine a little bit on how you see the world we're in now and where we're headed, and then we'll go to Phyllis and ask the same question. So Jose, and just feel free to speak to the audience as if they were your family and friends.
Thanks, Ben. I appreciate the opportunity. Just listening to what you're sharing, I think one of the things that has always amazed me is that as humans, we face challenges and we actually learn and get better when we face those challenges. So I don't know, maybe I'm an eternal optimist, but I really believe that if you look at the history of mankind, it's challenges like this that have helped us really get better and transform. So if I listen, as I listen to you and I look at, the positive changes coming down the pike, it's because they are basically the result of a lot of efforts over years that, a lot of people have put their minds, their efforts, their resources to overcome the challenges of 50 years ago, right? And I look at the current challenges. To me, that also excites me because it's challenges that are going to transform the way we deliver care, the way we interact with each other to receive care. And I think the topic that that we're talking about tonight in terms of the advocacy and the self-actualization as a human being seeking care is really going to be at the crux of how we overcome the challenges of whether it's shortages, whether it's more pandemics, whether it's other disasters, or whether it's just simply individual, difficult times with an individual with their own health. And really, what I love about this, the crux of it, is two things in my mind. Number one is knowledge, and number two is advocacy or action. Right? It's not enough to know, but you have to know and then take action. And I think if the audience thinks about it in those two categories, they will be set to succeed regardless of what the future brings, which we can talk more at length. I would also love to hear from Phyllis because she's been in that field for a long time.
Yeah, one of the things that I thought I'd like to throw out, because it struck me as we prepared for this program, because I'm old enough to have had very, very old parents a long time ago. So and that generation, which were, people who went through the Depression and World War II, they were very tough folks, but they were very passive in their healthcare. And you can still see that in Europe and certain places today. People walk in, they basically explain what's wrong, and then they just wait to be told what to do. And that's a complete contrast to what we need patients to do. And I think a lot of times, certainly, Jose, you as a physician, and Phyllis, I'm sure you've observed it, a lot of people think that's what the doctor wants you to do. They don't. They're much happier with and it's a lot easier to work with a patient who's really engaged, takes responsibility, and says, what do I need to do, and what am I missing? Am I correct, Jose? And then Phyllis, let's go to you.
Well, I don't, Jose, I think you paint a much more positive picture than I would. I spend a lot of time on webinars, and just about all of them are about discrepancies uh, social and gender differences. The fact that while there is, we can be sort of excited about AI and new technologies, there's still a good proportion of the country that doesn't have access. We discussed a little bit earlier that, and a part of this has to do, of course, with Roe, although things changed a little bit yesterday, but we don't know where it's going to go in the future. A lot of doctors are just leaving, especially gynecologists and OBGYNs and primary care are leaving different states where, for political reasons. I think that there's while there are treatments, certainly more treatments now than there were, and I'm probably around the same age that you are, is that there's increases in obesity and diabetes and cardiovascular issues. I mean, there are a lot of things that are a lot of conditions that are occurring now that actually, even though we had obviously cardiovascular issues forever, although I will say, and one of the things that I did when I was at the society was convince the American Heart Association that women had heart attacks, because at that point they didn't think that women did, and we've made some progress on that. But so I think there's a lot of disparities. I think there's a lot of people that can't access. And while AI, on the one hand, I think is very exciting, I still think you need sort of the bedside manner. You still need to have some relationship with a physician. It's not enough to just do everything, on a computer or telemedicine. I think there's advantages to it, but it doesn't replace it.
Yeah, Phyllis, I don't, for what it's worth, I'm deep into healthcare and AI. I don't know a single person advocating that you only work with the AI. It's much better to think, a much better model to think about is airline pilots. If you imagine, people worry about trusting their lives to computers, but the fact is, pilots have not flown planes for 30 years, and it was the biggest single increase in safety ever achieved when they stopped, and then the computer flies the plane and they monitor it. And that's the model that we see, is that it's a supplement to the pilots, or the pilots are monitoring or driving. It's much more like a drone driver. So I don't think you need to worry about computers completely replacing personal interaction, because it's always going to be needed.
Well, I don't want to.
Yeah, we just simply don't have enough clinicians, and we can't produce them fast enough to address the demand if we don't supplement them with having tools. And that's what it is. It's a tool to them. It's just like any other tool.
Right, but people have to, and I don't want to get into the airplane, because we know about the two disasters that occurred because of the monitoring. But so, nothing's perfect. But I still think people have to have a certain ability to access and also have the financial resources to get care when they need it. I do think we need to sort of start at the beginning. I mean, our healthcare system just isn't working. And we know that there are people that go, don't have doctors or don't have access or can't pay for the insurance. So, what we need is health care for everyone, so that everybody can get the health, the care that they need. And we still death and maternity issues and premature babies is still the highest in the world.
Phyllis, I completely agree with you. I'm sorry, go ahead, Ben.
Oh, go ahead, please, Jose.
I was going to say, Phyllis, I completely agree with you. Being an optimist does not mean I'm not a realist, right? So I'm a cancer doctor by training, and that's where I spent most of my career. But then I also moved into quality and safety for the very specific reason that you're mentioning, which is I went into oncology because that was the biggest killer of people, and I wanted to be part of the solution. I went into quality because I realized that the way healthcare is designed and the way we deliver care, unfortunately and unintentionally, actually causes a lot more harm than cancer, right? And I've always been of the mindset that, when I tell my patient I'm going to admit you to the hospital, should they be comforted or should they be terrified? And the reality is they should be terrified, right? Unfortunately. And it's not because the doctors are, ill-intended, or the nurses are ill-intended, or the healthcare executives are ill-intended, or the insurance companies are ill-intended, or the drug companies. It's just because we have not really designed safe, high quality, reliable systems that are human-centric, that really are meant to and designed intentionally to create and maximize that human interaction while taking away a lot of the other tasky items that don't add value to that human interaction. And I think this is where the shortages that we're talking about, the challenges in access that you're talking about, the disparities that we're seeing. Yes, we need to address all of these, but I think the technology augmenting the human element can make a big difference in the future. I think we've maximized what we can do in terms of one human at a time. And I think what we need to move into is more of a team-based approach where the technology is part of the team. And so imagine the following, Phyllis. So I'm a cancer doctor, right? I come to clinic and I have 20 patients for a day. There's probably, out of those 20 patients, there's 5 or 6 that needs me to spend maybe an hour and a half, 2 hours maybe with each. The other 15, maybe another 5 need me to spend about 20, 30 minutes. And the other 10, all they need is just to know that they're okay. And, maybe a hug from me and a high five and move on, right? But there are some other things that they may need. They need to know when's their next appointment. They need to know what the next tests are. They need to know what could happen if, they travel, or what vaccines they may need for next year, right? Is that information required by me as a physician? Not necessarily. They could talk to my nurse. They could talk to my nurse practitioner. Maybe they could talk to my avatar, right? An AI-based Jose that can answer like Jose does on items that are, algorithmic in the sense that they're relatively predictable, right? The answer to what are the vaccines that you should get next year? There's a few items that I look at that determine my answer. And so it's relatively predictable and standardized. In the same time, that allows me, if I had that backup and we changed our care models to where you interact with different people on the team that give you information, and we as a team get together ahead of time and design what would be the answers and who takes care of what level of questions, then I can maximize my time with those who really need me, where only I can answer that question. And then they can also maximize their time with my nurse when, for example, if they need a central line to take chemotherapy, guess who's the best person to answer that? The nurse, and not me, right? And so if we look at it more as a team approach, and we consider the technology as part of that team, and we really also can take into account the community, we're a lot more likely to be, and the community resources, we're a lot more likely to be part of a more effective team to provide better care. I'll share this simple story with you. This was about 10 years ago. I didn't think at that time, I wasn't thinking too much about diversity and inequities. I used to take care of patients both at a county hospital and at an affluent academic hospital. And at that time, I was the academic hospital. When I was at the county hospital, we would always think about, do you have enough food at home? Do you have transportation? Are you feeling safe? Right? Do you have a bed to sleep in, et cetera? At the affluent hospital, we never thought about these things. I had this patient who kept losing weight one cycle after the other, and I'm thinking he's having side effects from chemotherapy, maybe nausea, et cetera. I would ask, and he's like, no, I don't have these things. But I was still intrigued, so I was decreasing the dose of chemotherapy. After the third cycle, I get a call by my nurse from the infusion area, and she's like, why are you reducing the chemotherapy? And I'm like, because he's losing weight. And she said, do you realize that this guy is taking all our crackers and all the sugar that he can get his hands on, and he's stuffing his pockets with this? I said, wow, why do you think he's doing that? And she's like, we asked him, and he doesn't have food. He's going through a divorce. This is a guy who's employed, right? He has a job, he's working, but he got divorced. He's paying a mortgage and a rent. He's having to support two households. He's running out of money.
Right.
And he's going through chemotherapy and treatment. And so my point is, maybe I'm not the best to identify that, but if I had a system around me that could really proactively ask those questions, that could proactively seek that information and present that information and synthesize it and present it in a way that allows me to see what's relevant, allows my nurse to see what's relevant, allows my pharmacist to see what's relevant, we would be able to deliver better care. We're not there. We're nowhere close to there, right? It's very chaotic right now. I agree. But the challenges we're facing are going to force us to get there. Just like, the challenges we were facing 50 years ago, where we didn't have chemotherapy, we didn't have immune therapy, we didn't have, targeted therapy, we didn't have personalized therapy. But we developed all these because we wanted to solve the problem of cancers. We wanted to solve the problem of heart disease, right? And I think right now, unless we think about the problems of our inequities, our, the dysfunctions in our healthcare system, and the problem with our staffing and our ability to, the limitations we have with the number of doctors, nurses, pharmacists, et cetera, that we have. I think once we start looking at those problems as solvable problems through a different model of care and a different mindset, I think we have a really good chance to deliver a much more humanistic healthcare.
But if I can just interrupt for 1 second, because
Sure.
that story, Jose, goes to the heart, I think, of our topic this evening. What could that patient have done as an advocate for his own health care? I'm standing here, sitting, as unlike you, as simply a consumer of health care. And so I'm wondering, and it's really a question for everybody, what do we have to think about? What should people like me, consumers, people like your patients, be thinking about? People like a woman who doesn't necessarily understand what her condition is, what's wrong with her body. What is our future role? What should we be doing to be the best advocate for ourselves when we are even more lost than you are in this maze?
Well, I think that's, I think what Jose is saying is, in a perfect world, and that would be great. But, I hate to be, such the pessimist, but obviously I am. There are so many, we all know that most people don't have more than about 10 minutes to spend with their doctor. You're an oncologist, and obviously I would assume an oncologist, for various reasons, spends more time with their patients, obviously. But most patients, have 10 minutes, and they're lucky if they go into a particular issue, and perhaps that's addressed. But one of the things that we're other webinars that I'm attending is looking at holistically and looking at mental health issues as well as primary care issues, and it's very difficult because if you have so little time with each patient and you have so many patients and a dearth of doctors and nurses, you don't have the time to really go into a person's what's really happening with them. And of course, a lot of people, and again, from my perspective, and I don't know whether you're aware of this, but I have a book that's coming out in April, and it talks about sex and gender and racial differences. And so that's a whole other issue. And there's a lot of disparities, a lot of misdiagnosis or undiagnosed issues. Doctors either don't have the time or ill-equipped or just brush off patients' complaints. So there's, what I come right back to our system, the way Jose is describing it would be wonderful. But the problem is that that's not the system that we have. Certainly not in rural areas, and certainly with people that don't have the resources, either financially or intellectually, or the ability to access the right care at the right time and see the right doctor.
Phyllis, what is missing, though, I think that I want to, at least, and you don't have to believe it, but the only way that we can see today, and I say we, I think those of us who are trying to build something better, is two things that address both of your main concerns: disparities and between care, and having enough a physician time or clinician time. And that is to be a force multiplier. What artificial intelligence and other technologies can be are force multipliers. They take a person and they create more than a person. I don't know whether you're aware of this, but I'm sure you've run across it. That one of the things we've talked about for 30 years in healthcare is people operating below their license. Everybody does. It means that if I'm a nurse, I'm doing non-nurse work. Jose does non-physician. He's a very valuable resource. He does stuff he shouldn't have to do. The very first place we can use artificial intelligence is it does those tasks. So now we get 30% more of Jose. We get 30% more of nurses. The second thing is that through, as he was mentioning an avatar, things that he can answer without personally being there, that his alter ego could answer for him, and can answer, but it doesn't mean that they can't still talk to a physician. The very first thing they would say, it would say to them is, if you're not happy with the answer, you text and Dr. Azar will get back to you. That's force multiplication. That's taking the resources we have and making them greater. The second connection is personalization. Now, that's not going to happen overnight, but if we don't have AI to help us, we'll never get there. And personalized medicine jumps over the problems of disparity because it's all driven to the individual. And because you can produce it a lot more economically, we think we'll be able to, that'll be one of the great fixes of disparity. And it's not 30 years from now. It may be 10, but it's not 30. And that these tools will be available.
Ben, there is, just to link it back to what Fred was saying, there is a couple additional pieces to what you're saying that the individual needs to own to really leverage all what you're describing. And just I want to be clear, Phyllis, I completely agree with everything you're saying.
Yeah, I don't disagree.
The only difference that's
today.
The only difference between what you're saying and what I'm saying is I'm looking 10 and 20 years from now, and I'm looking for a future where we actually solve the problems that you're highlighting. So I'm very realistic. I see that I live the problems that we have every day. What Ben mentioned, for example, you can free up you can have more physicians. So let's talk about physician time, right? If a physician has 10 minutes per patient, there's two things you can do to help physicians have more time. Well, let's put it comprehensively. Three things. First, the physician needs to have a mindset of, I want to spend more time. I want to spend more value time. I want to spend more face time, and I want to listen and really interact and connect with that human being on a human level. So that's what the physician can do. But then the system needs to free up more time of the physician, and it frees up more time. If you look at the electronic medical record, and by the way, I'm a big proponent of the electronic medical record, but not the way it's structured right now.
Right.
Think about it this way. Who asks a pilot to go back and document and chart their flight? Do you want your airline pilot to spend the next 2 hours writing what altitude they were flying, what decisions they made, how did they, nobody, right? You have a black box, it records the whole flight, right? Simple solution. Why every physician, after they see you for 10 minutes, they have to go back for 10 to 15 minutes to write down what they did for you and with you and what they discussed. If you look at what time physicians chart, we call it pajama time. It's at 10 p.m. after they've had a whole day. And guess what? They're going back to see patients again the next day. They're exhausted, right? Why? Why not? I have an earpiece. It records everything I say. It's smart enough to say it's connected to my computer. I tell you, listen, you need a CBC. It orders a CBC. Right now, my phone, right? I can pick up my phone and say, hey, Siri, get me an Italian restaurant and make me a reservation. Siri can do that. Yeah, I only paid what, $1,000 for my phone, right? We pay millions of dollars for our electronic records. They're not smart.
No.
They can't do that. But imagine if I didn't have to go record and say, I just talked to Phyllis. Phyllis said so-and-so. I examined Phyllis. I found this and this. I told Phyllis I think she has this and that. And I think Phyllis needs this test and that test. Why do I have to go back and type it or write it or dictate it? Why not have an earpiece? It records everything. It orders everything that needs to be ordered. And now I can spend 25 minutes with you. So that's one part. The third part, though, if you have 10 minutes and you are educated, I don't mean educated by degree, because you know what? When I go to, I'm a physician. If I go to a physician to talk about X, Y, and Z that's not cancer related, or even if it's cancer related, I get overwhelmed. I have emotions. I don't know everything. I went to medical school. That was 25 years ago, right? A lot has changed. So if I need cardiac care, I don't know much about cardiac care. I need to listen to my doctor. But what's really critical is knowledge and action. If I took the time to read on Google or on some journal, or maybe I have an AI interface that can actually teach me and educate me, or maybe the doctor that I'm going to see tomorrow actually has an AI interface that can tell me 80% of the things that I need to know ahead of time, right? And then they personalize it and they build on this. I can come prepared. That's one. That's the knowledge part. The second part is not to accept, take action. So if, like you said, right, I'm not feeling right. If I'm a woman and I'm not feeling right, I have a little bit of discomfort. Or if I'm hungry and I'm losing weight because I'm hungry and I don't have food. If a physician or a nurse judges you or dismisses you, you know what? They're not worthy to give you care. And you need to find somebody else. That's the first action you need to take. If a physician tells you don't read on Google, I'm sorry, but you need to fire them. This day and age, you need to educate yourself. It doesn't mean you have the answers. It doesn't mean you will know what exact diagnosis you have. It doesn't mean you will know exactly, what the actions need to be and what medicines you need to have. It doesn't mean you graduated from medical school. But, I go to my financial advisor. I know nothing about finance. I read about finance before I go to them, not because I'm going to manage my finances, but because I need to be able to talk to them on the same level.
Yeah, and I think that's a really good.
Critical.
That's a really good example for at least, and again, not everybody has access, but a vast majority do, and more people do every day. But that's a practical thing. Is first, I think you said several things there that are important. First of all, is be ready to fire somebody who doesn't give you the service you should.
Exactly.
And then do your homework before you engage, because the more you can come in with good questions, good comments, disclose, and don't hesitate sometime to walk in with a typed sheet of paper. If you don't have enough time, say, when you get a time, please read this, because this is things we're not going to have time to discuss today. Something like that.
Some of the best encounters I've had is when a patient comes in and says, okay, this is what I'm feeling, and these are the questions I have. It cuts at least 15 to 20 minutes of the time.
Phyllis?
Right, go ahead, Phyllis.
Yeah, I mean, obviously I do that. I mean, if I have certain symptoms, I Google it. I call my doctor. I basically tell them, I mean, I'm educated. I know what to do. I advocate for myself, but everybody's not like that. And a lot of people, they trust everything their doctor says. I don't know if everybody goes on Google, whether they understand what they're reading. I think yes, I mean, you can take care of yourself. You can, I was asked by a company a while ago to go through resumes and personal experiences of patients that had different gastrointestinal conditions, and they had to write their personal stories. And I had to go through about 60 of them to find 10 that got scholarships. Every single one of them had spent years finding the right doctor, the right diagnosis. They suffered. I mean, it was just one horrible story after another. And luckily, for whatever reason, and for what they all managed to survive, to finally find the right doctor. Sometimes it took years. It's just, everything you're saying is true. And if people could all do that, and if doctors would listen, it would be great. It's just that some people are intimidated by their doctors. If their doctors tell them that, don't worry, it's okay, you'll be fine. This book that's coming out in April has patient stories of women, obviously, who have been sort of dissed and told not, if they're in pain, they're not taken seriously, or they have different heart symptoms and the doctors don't recognize them. I mean, I hate to be the naysayer here, but that's apparently the role that I've got. Working in healthcare for over 30 years, it's far from perfect. And yeah, there are a lot of good doctors and a lot of intelligent patients. But there's also a lot of people that don't have the wherewithal to do that and don't have the access either. So I agree, the future holds a lot more possibilities with AI, telemedicine, to help people to get to people that might have other issues. But still, they have to be educated. You have to have a certain amount
I agree.
To ask the right questions and to know if your doctor's not giving you the treatment that you should get.
One thing that I'm encouraged by, because again, nobody disagrees that nor me that we've got a long way to go. But I also agree with Jose. This is the thing that causes invention to happen.
Yes, no.
I'll give you an example. The company I mentioned before that my son's running, that they're directly focused on disparities of care in Medicaid, working with the Medicaid doctors, the people in the offices treating those people. They have to see 60 patients a day.
Right.
I mean, it is challenging, but they're trying to build ways that they can advise those patients, give them the best possible advice in the time they have, and do the follow-up. And we're using automation a lot, but also some very training the people in the practices differently. So I'm encouraged, but I do think that what you're talking about is how do we get there as fast as we can. And tonight, of course, what we're speaking here to is the people in the audience. What can you do? And I think we've given them some practical things to do. Prepare. Whatever you do, prepare. Don't be shy. Don't hesitate. If you've got a provider who repeatedly doesn't listen to you, you should tell them, I'm going to have to change you if you don't start listening to me. And if he doesn't change, then then leave. Find somebody else. But
I'd like to ask you, Ben, and the rest of the panel, do you think that there might be some people who might be more apt and more willing to talk to a machine, a non-judgmental machine, than to say to somebody face to face, I don't have enough food? To say to somebody face to face, I'm having hallucinations, something, whatever that embarrassing fact is. And so that's one part of the question. And the other part of the question is, what can we do to make a consumer like me, a consumer of medicine, to feel more comfort with this idea of, okay, I will go to telehealth. I will speak with a robot or a machine, because I think that kind of gets to the crux of, taking responsibility and moving forward with your own advocacy. That's the challenge, and that's also maybe the possibility.
Yeah,
I can interject.
Go ahead, Jim.
Yeah, I think there's a couple things. One, you're absolutely correct. It's actually very interesting to see, when what people would share if they're just messaging their physician versus if they're sitting with their physician. And also, it's interesting when we move to virtual care, and psychiatrists and psychologists would tell you, people are a lot more open, even on a virtual screen, than they are in person, right? So I think that's part of the learning that we need to do to really create safer spaces, to where, we, by we, I mean healthcare systems, the different offerings, the different touches that we can offer for patients, to where we give them access through texting. We give them access through an avatar or an AI. We give them access through a virtual offering. We give them access through an in-person visit at different levels. But I think this is why I go back to that team approach. If they know that all of these offerings are designed intentionally by me. So, for example, imagine this. If the third-party payers, if CMS, if the government paid me as a doctor not to record, how many organs did I examine, because that's the way they pay me right now, right? If you come to me with a left toe pain, they ask me how many systems and they count how many systems. Did I listen to your heart? You get a little bit more if you listen to the heart. You get a little more if you listen to the lungs. Well, why do I need to listen to the heart? You're talking to me. Your heart must be beating. Your problem is in your toe, right? But what if they paid me to spend time designing systems that work better for patients? What if they paid patients to help me design systems that work better for them? And this is a crazy idea. What if we paid patients of a lot of different, backgrounds, diverse, maybe genders, sexuality, racial ethnicities, socioeconomic backgrounds, to help us design better access for them, right? What if we did that? But then the other part, to me, is it's a relationship. So we can make it safer, and I think we need to make it safer for people. But also, there's another part. We need to make it also more normalized, right? And what I mean by normalized is the following. If I only ask you about your food insecurities when I see you losing weight, so going back to my story, right? I'm not being proactive, I'm reactive. And to some degree, it's a judgment by itself, right? Why am I asking Fred if he has food and I'm not asking Phyllis if she has food, right? What if we ask those questions consistently of everybody? And maybe if we ask those questions, not in person, but we just, hey, listen, we have a series of questions that we'd like to know about you. We really want to help you. A lot of people, have these challenges. We would like you to answer those questions before you come. And you can answer those questions and they can be directed to the appropriate people, but we normalize it so that every time this is a normal thing that we ask. I introduced about, 11, 12 years ago, a psychosocial assessment to where in oncology, we used to only ask people who are distressed if they needed support from an emotional standpoint. We changed that around. It became, we sent a survey ahead of time to every patient to say, cancer is a very stressful situation. It can stress you. It can stress you emotionally, physically, and financially, and with your relationships. And we would ask questions about these different categories. We didn't ask if you had enough food. We didn't ask if you had the right transportation. We didn't ask if you're threatened at home or you're afraid for your life. We didn't ask if you're at risk of losing your job. But what if we ask those things?
You know what, Jose, and it's interesting because I don't know whether, I don't think, I live in Arizona, in Scottsdale, in Paradise Valley. But I've had the not so good fortune, but to be in 3 healthcare systems in this area in the last couple of years, 3 different ones. Normally, I'm just a Mayo patient. They always ask those questions.
Yeah, we're
Every
studying
single time they ask about, do you have enough food? Do you have this? Do you have that? Are you safe? And so and it's not just Mayo. You would expect that of Mayo, but it's of a couple of the other big systems here that have a much broader demographic, and they all ask me those questions.
And that's what we're all doing, right? Like most healthcare systems are doing that. We do this at Hackensack consistently.
Right.
But that's the intent of it. When you normalize it, it becomes less of a taboo, right? It becomes less of a stereotype too.
That's one of the big opportunities, I think, with an interface that's whether it doesn't even have to be, whether it's AI or whether it's just a normal kind of system, to basically do a lot of triage, a lot of before you even see a clinician.
And that's where electronic systems could help.
Yeah.
I also want to say the work that Phyllis does, for example, right? The advocacy. I mean, how do we amplify that? So imagine if insurance companies, instead of paying a boatload of money for when health breaks, they actually support, Phyllis's work.
Right.
And they support people that work with Phyllis. And we create health coaches that actually go into all communities, including communities with the most needs, right? And the most vulnerable communities. And they actually coach people,
right,
and encourage them and empower them and give them materials so that they know where to look for information, and also give them coaching on how to speak to their physician. But I'm going to say it again. Physicians are not gods. We don't walk on water. We are just as human as everybody else. We make mistakes. We get tired. We have emotions, right? And sometimes we need to be given some grace. And sometimes maybe we need to be held accountable and fired, right? I mean, that's the basis of it, right? If you go to a physician and they're not listening to you, you need to let the physician know, you're not listening to me. I have an issue here. And if they still don't listen to you, you need to go find somebody else.
Right.
And maybe you don't have that courage yourself, but if we had advocates like Phyllis, or if we created a system by which people get access to somebody that can encourage them, give them the information, and encourage them to take the right actions and advocate for themselves, they would be more encouraged.
I need to ask Phyllis a question at this point, which is, Phyllis, the people you advocate for, what do they need to hear? Is there a model of language they need to hear? What is it that they need to hear so that they can move forward?
Well, what we do really is what Jose says. I mean, we have this program called Women Talk, and we talk about every condition imaginable, that women can suffer from, and what they need to know and what they should ask their doctor. I mean, we do that. And there are a lot of nonprofit organizations that are doing great work, also doing the same thing. But still, there's a dearth of knowledge. I mean, we're talking about the telehealth. Before I got into women's health, I actually worked for the American Psychiatric Association. And, what Jose is true. I mean, a lot of people who would use telehealth for mental health issues would reduce the stigma, and they prefer to do that. And also in terms of travel and stuff. So that was encouraging. And also I was involved with another organization that did prenatal care and postpartum, also for women who couldn't access doctors regularly. I mean, there are systems out there and there are programs out there. It's just that, we need more funding. We need coverage. That's gone back and forth in terms of coverage for telehealth. I think I was involved with an organization. They were trying to get coverage for opiates. obvious, and that obviously has its own, issues. But if you need them, and they need to be prescribed. So there was a lot of talk about whether they should be covered, whether insurance should cover it. So there's a lot of issues that surround these. It's not just contacting your doctor and doing a telehealth thing. So there are, I mean, we do what you're talking about, trying to talk to women about what they need to know, what they should do, and bringing to light a lot of conditions that aren't usually talked about, menopause and issues that relate to them. So yeah, we're doing that. It's just that again, I said at the very beginning, the health system is just there are a lot of people that are doing very well by it, and then there are a lot of people that aren't. And I mean, we've discussed this. I mean, Obamacare, I mean, it was certainly better than it was before because there are more people that it covered, but it doesn't cover everybody, and there are still issues. So, and then we talked about this earlier about doctors leaving, and I'm curious, what are doctors in medical schools, or what are medical schools teaching about AI and telehealth, and how has that changed the curriculum from what it used to be?
Yeah, I think that's a great question. So I'm going to answer it in two different ways. The newer programs are really catching up to the times, but you have to remember that a physician stays in their profession for about 40 years or more sometimes, right? And close to 50. So, I mean, I graduated medical school in 2002. We were never taught how to communicate with people. We were never taught how to use technology because the EMR was not there. We were never taught how to work in teams.
Yeah.
Right? We were never taught to really think of the patient as a human being per se. We were taught to be investigators. And just simply that term, just put that term, right? You're an investigator. What does that make the patient on the other side?
Right.
A suspect.
A suspect.
Another term we still use today. I mean, not just in medical schools, but everybody talks about the front lines. Front lines against what? If I'm a physician at the front line and a nurse is at the front line, what does that make the patient? The enemy? Right? We're caregivers. But yet we're not taught traditionally in the old days, right? We were not taught, my generation was not taught to actually take care of humans as humans and really create those relationships. I spent endless hours in the lab looking in the microscope at people's blood, but never really learned how to look in their eyes or even sit in front of them at the same level. These are things we learned later. Now we teach those things in medical school, right? I'm excited about our medical school, which is very new at Hackensack Meridian. We launched medical school about 5-6 years ago. And we teach AI, we teach telehealth, and more excitedly, we have the Human Dimensions team course where we actually embed our medical students throughout the course of a year with a family. And that course has really led to medical students creating different solutions in their communities. Like, for example, one of our medical students measured that their family that they were with needed to take 5 different buses to travel 10 miles from their home to their clinic, to the clinic. Now, imagine this is underserved. Right. So that basically means they're taking the whole day off. That family is basically on a very limited income. Taking a day off, right? Ben has the luxury to take a day off. I have the luxury to take a day off. My salary is the same. A day off for them, that's basically one day they're spending without food because they're living paycheck to paycheck. So they have to take a day off to go see the doctor. So they're going to have to choose, do I go to the doctor or do I get my food at the end of the day? Guess what they're going to choose? I don't want to be hungry. I don't want my kids to be hungry. I'm not going to go to the doctor. The beauty is that that medical student, with the support of our medical school, was able to actually talk to the mayor, and they created a different bus route for that community that goes straight to the medical facilities. What I'm trying to say is we have to change our systems. The systems are broken. Our social systems, our community systems, our healthcare systems, our insurance coverage systems, right? All of these systems are broken. We have to fix them, but we can. If we look at those problems in a positive way, we can overcome that by changing the route of how we are trained as physicians, but also by the work that you're doing, Phyllis, right? And if we amplify the work that you're doing to empower people to advocate for themselves, which is basically, again, I go back to that concept, knowledge and action, right? I need to take action, and I need to educate myself, and I need people to support me in educating myself.
So I think we're getting close here to our time. One of the things I wanted to do before we close up is just mention that for those who do have some financial means, you don't by any means have to be wealthy, and the stuff's getting more inexpensive all the time. But the home diagnostics and the wearables are becoming really powerful. And there's a real scientific opportunity here that we've never had before, which is longitudinal monitoring of large populations, right, Jose? We've never had that kind of information before. Yeah. And that's really significant. And these are not terribly expensive devices and that's today. Give it another 5 years and they'll be affordable by everybody. So whether it's the Oura Ring, whether it's watches, whether it's a health band, these things are really starting to bite. So yeah.
We really are. It's true. We are running out of time, and it's been an extraordinary, sobering, instructive, deep conversation. Ben, do you have some closing comments for us for this session and for the 3 sessions?
Yeah, I think just to recap that, if you listened to this entire program series, you've heard a panel speak to some of the amazing science coming down the road that's going to ultimately lead us to personalized medicine and some cures potentially within the next 10 years or so or prevention of major diseases, cancer, and many types of heart disease, even perhaps some of the dementias. And that's very exciting. We've got big challenges. We've been talking about some of them here that we have to address. And then finally, here tonight, we've had some really, I think, very good suggestions. First of all, just understanding that it's not possible to be passive anymore. It really isn't. And it's not possible to count on necessarily that someone else is going to advocate for you. Wish it were true, but it's just not going to be. And so for everyone who has the ability to do some of their own research, to be a very strong, good patient, be a good patient so that when you're working with a clinician, you maximize that time and use that time well and get the most out of it, I think is the main message of tonight. And it's headed your way. I mean, it's there's a lot coming your way to help you do that. So I think that's the way I would summarize it. And thanks so much to Jose and Phyllis. It's been a really spirited, wonderful discussion.
Well, thank you, Ben. That was a wonderful summary. Thanks, and thank you, Jose, and thank you, Phyllis. There's so much more to say. There really is, but unfortunately, that's all there is for these sessions about the future of healthcare. Thank you so much for joining us.
Thank you.
Thank you. And if I may, just one quick thing. Nobody cares about you more than you. It's your life.
Right. That's right. Well said.
Thank
Thank
you.